It's my pleasure to be part of this DiaCare conference, and I am thankful to Dr. Sabu sir and team and the big vision of Dr. Sabu by involving every part of world in this conference. And here is Julia Maddow from Austria, Associate Professor of Medicine, Division of Endocrinology and Diabetology. Julia Maddow is currently Associate Professor at Medicine in Division of Endocrinology. She received her medical degree at Medical University of Graz, and she also trained in internal medicine and endocrinology. From 2016 to 17, she was visiting professor at the Department of Diabetes. She leads the Diabetes Technology Research Unit at Medical University of Graz. Professor Madder's research is focused on diabetes technology, emphasis on insulin pump, CGMs, artificial pancreas, decision support systems. She has published over 90 peer-reviewed scientific papers and serves as an associate editor for the trials. She has received several national and international awards. Professor Madder is member of European Association of the Study of Diabetes in Austrian Society for Internal Medicine. She is management board member for Austrian Diabetes Society, within which she heads the Diabetes Education Committee. So, with this all accolades, Professor Madder is here to share her wisdom on this part because she is doing a lot in diabetes and technology. So, over to you, Julia. Please share your screen.
Sorry, it did just some technical issues. Shortly, it will hopefully open.
Can you click on the share screen button, the green button?
Yes, it works, but it doesn't open. Yeah. It doesn't open the files. Ah, yeah, here it is now. Sorry.
Yeah.
So sorry for the short technical issues that we had. So thank you very much for having me for your huge conference. I'm very impressed about the agenda and the audience. And I'd like to talk to you now about SMBG and remote monitoring. So we already had a very good introduction into telemedicine and what can be done by telemedicine. And now I just want to focus on the smaller part of self-monitoring of blood glucose in that field.
Ma'am, we are unable to see your slides. Can you share the slides? We are seeing your inbox.
Ah, okay, so it did not show the slides even if I'm now...
No. Can you try again?
I'll just close this one.
Yeah, you close this one.
Can you see it now?
Not really, no.
No, not yet.
No, ma'am.
Not now, neither?
No, neither.
Yeah.
Do we have a backup slide for ma'am?
Yes, I sent it to Dr. Sabu via WeTransfer.
Yeah. Ankit?
Ah, maybe now it works. Just one more.
Yeah,
more
working.
Try.
Yeah.
Working.
Sure.
I can see it.
It's visible. It's visible.
Yes.
Yeah, it's visible.
Okay. Wow. Sorry so much. So okay.
Oh,
here's my conflicts of interest. And yeah, as all of us are aware, the challenges in diabetes management are present every day, and this is present in all of the year, may it be health, may it be vacation, may it be living under conditions of pandemia. So diabetes management is challenging all of the time. And it's sometimes like walking on a tightrope where you have to, on the one hand side, avoid hyperglycemia, and on the other hand side, avoid hypoglycemia. So here I want to share two very important figures that I sometimes also want to discuss with my students and with my patients, because that helps them maybe to get some empowerment, and it's maybe not so easy to discuss in such a setting. So I just want to show you what these figures mean to us. Usually we have about 2 hours with the patient where we can discuss issues and help him to better understand his diabetes and maybe better understand treatment decisions. But nearly 9,000 hours a year, the patient has to treat his diabetes without our help. So we have to give him kind of a kit to enable him to manage his diabetes alone the best possible way all over the year. And of course, some of the hassles that we do have, especially in people who do self-monitoring of blood glucose without a sensor, we just can see the dots where the measurement is performed, but we have missed areas, especially harmful in the low areas, but of course also interesting to see how, for example, postprandial glucose values would evolve. Additionally, once a patient either comes into our clinic or he shares data with you, data entries sometimes are difficult to read and difficult to interpret, especially in self-monitoring of blood glucose. And I think you in India are even more advanced than we are in Austria, because we do not have such good regulations for telemedicine. So lots of our nurses take the calls via telephone, and then patients just tell them some numbers and they have to figure out how to really use or make use of SMBG. And in that sense, of course, digital data collection could be of great importance, and just one part of it would be the self-monitored of blood glucose, but of course we could also integrate health data from devices that collect heart rate and collect activity, or we could collect data from connected pens, where we have then the insulin dose together with the blood glucose value, or even track the blood pressure of the patients. And once we have such a connected platform, of course, it's a holistic system where we can easier understand and easier interpret patient data. And COVID, in that sense, even helped us here in Austria, because a lot of the patient visits were transferred into virtual visits, both for patients using SMBG, but also for patients, of course, using continuous glucose monitors. And connected device data can then be shared with the physician, and we have currently various platforms that we allow in our clinic, where we get the transferred SMBG data and can then discuss in a video call the data with the patient. And there are several software solutions, and it's really good to have good software, as we heard before, just for storing the data, but also to help us to interpret where are the problem areas, because then we get the green code or the red code or the orange code if glucose values at a certain time frame are too high or are too low. And of course, some of the tools which were developed even by patients and then sold to bigger companies have challenges around them and kind of motivate the patients to measure their blood glucose frequently enough, and also motivate patients to achieve target values as recommended. And on the other hand side, such platforms have the potential to transfer the data then to us at the clinics. And why could also be telemedicine and remote monitoring in SMBG be useful? As we heard before, there are remote areas, and of course, in all of our countries, the experts are not available at every site. Patients do not need to commute, and you can interact more frequently. There are special populations who could benefit a lot, especially children, for example, pregnant women, or also people who need support, like elderly persons. It gives you flexibility, because people who need to work do not need to take the commute on the one hand side, or if you, for example, go to study in another city, you do still have the chance to communicate your blood glucose values to your treating physician at your city of origin, and you can keep care in that sense. And of course, the pandemia made us aware of kind of the risk of infection when patients have to wait in a waiting room together with other people when they are on the commute to the clinic. And of course, also patients are afraid of visiting hospitals and clinics at the moment because they fear that they might get infected here. So what we saw not only in our department, but also in the emergency room, that patient visit in physical, they reduced because people just simply did not approach us. So it was completely different to Italy, where they had kind of overcrowded emergency rooms. In our emergency room, visits extremely dropped. But on the other hand side, we had a lot of acute admissions then from patients who were with their glucose way out of control and had ketoacidosis and had high blood glucose values, or even suffered from a very bad diabetic foot syndrome infections, who had then to be amputated. So it is really, really important to kind of have the chance to take good care of our patients even in these difficult times. And just to shortly mention type 2 diabetes and COVID. So there is a large proportion of patients who have diabetes who then suffer from coronavirus disease. And this is why it is important to take good care of our patients also in that situation, because what we saw, people who have both type 1 and type 2 diabetes and are out of control. So we have good glycemic control for the both groups to the left. So we have type 1 in the light blue and type 2 diabetes in dark blue. And to the left, we have good HbA1c, and to the right, we have not so well controlled diabetes with HbA1c above 10%. And we do see increased mortality in the ones with uncontrolled diabetes. And what we also see when it comes to urgent admission to the hospital, people who arrive in the hospital without previous good glycemic control, they suffer higher mortality and they are diagnosed with COVID-19. And so how can we use telemedicine in self-monitoring of blood glucose? There was a study performed by German colleagues in 900 people with type 2 diabetes taking insulin, and they were seen in 101 practices all over the country, and they were seen over 12-month period, and they had intervention versus standard care, and they assessed glycemic control, patient-reported outcomes over that study period. And I just shortly want to show you that system. So they had this integrated personalized diabetes management, where they had the structured documentation, structured and systematic analysis of the SMBG data, personalized then the therapy to the patient, assessed the efficacy over time, also had diabetes educators who structured education, and then adjusted the therapy to optimize the glycemic control. And that was kind of a continuous cycle that ran throughout that year, where that cycle was reassessed with every iteration, and then the glucose control after 12 months was compared, and one saw that the blood glucose and the change in HbA1c at 12 months was significantly better in the ones seen with telemedical support, even when just using self-monitoring of blood glucose. And that drop was already seen at 3 months and then continued to stay until the end of the study. And another study investigated this for 24 weeks, so that was just a shorter study, and they had SMBG alone with regular in-clinic visits, which is usually every 3 months. And the other group, they had SMBG plus an app with even a text messaging service that was personalized to the patient. And it included both people with type 1 and type 2 diabetes. And it was the meter glucose that was assessed. So it was also not continuous glucose monitoring. And also in this group, one saw a drop in HbA1c over time, and that was more pronounced in the ones in gray, which were the ones using the meter and the app, versus the ones who just used the meter alone. And then, of course, it's also important to understand how people feel when they are treated with self-management support when doing SMBG and having telemedical support. And they interviewed people with type 2 diabetes aged over 50 years. And they wanted to know about the potentials of telemedical care when using SMBG, but also, on the other hand, side about concerns. And the people had mixed feelings, so they saw the potential of an increased involvement, better empowerment, and also felt secure, but they also felt a bit ambivalent and uncertain with the lack of personal contact. And if I just want to read out one of the sentences, which was of course, kind of prevalent in people. It's too difficult to use for me. I can't even type on the smartphone. So that was especially from the elderly ones. But as we heard before, of course, they could have kind of the support maybe from the family together with the patient and then do such a visit together. So that might be an opportunity to overcome such issues. So what could be the benefits of such digital healthcare support in SMBG? We have more comprehensive data, we have structured analysis, and then can do better decision making. We can support the patient when he or she is in need. It empowers the patient when they use the technology also to self-analyze their glucose patterns. It can be done remotely, which is helpful for the working population, for the elderly, for people who are in school, or for people who live in rural areas. There can be data transfer to other clinics. For example, when the patient is relocating, or the patient can still stick with his initially treating physician when he's relocating to another city within the country if he feels more comfortable, or you can consult another specialist if you share data and get their insight and their views on your treatment ideas. Of course, there is open questions left, which is, for example, how often should we see the patients within telemedical care? How often can we have in-clinic visits versus remote visits? Inert patients are, of course, difficult to treat anyways. What is the amount of data that is needed? Reimbursement is still not covered yet. Data security is sometimes still a concern. Then there are legal requirements. What are allowed platforms? What does the hospital IT allow you to use? And acceptance rates by patients might depend on age and education levels. And of course, the devices should be interoperable if there should be automated data transfer. Yeah, with that, I'm at the end of my presentation and would like to take questions if there are any.